Welcome back to the CARES VetMed Podcast, your one-stop shop for veterinary anesthesia nursing and so much more. I'm Tracy Mahoney, and I'm excited to break down the mysteries, the magic, and the everyday realities of this critical role in animal healthcare. Being a veterinary anesthesia technician or nurse is often shrouded with mystery. Still, its comprehension is vital to the health and safety of our furry friends. So, grab your favorite coffee or tea, find a comfy seat, and let's get started. In this episode, we will review a super important topic, blood pressure, and how it's affected by anesthesia. We will cover the basics of blood pressure, how drugs affect it, and what to look out for in our patients. This is a crucial concept for anyone involved in animal care, especially for all of us anesthetists out there. Think of blood pressure as the force of blood pushing against the walls of your blood vessels. It's like a vital lifeline delivering oxygen to all the tissues and organs in your pet's body. We call the organs that need a consistent and generous oxygen supply the vessel-rich group, or VRG organs. These include the brain, heart, kidneys, liver, and endocrine system. They account for 75% of cardiac output and play an essential role in keeping our pets alive. Here's the thing. For those VRG organs to function optimally, they need a specific pressure range, a mean arterial pressure, or MAP, between 60 and 150 millimeters of mercury will ensure they get enough oxygen to keep things running smoothly. But what happens when this MAP falls below 60 millimeters of mercury? Well, it's like trying to power your car with a near-empty gas tank. Those VRG organs start to suffer. In previous episodes, we primarily focused on the respiratory system and its role in regulating oxygenation and ventilation in our patients. Now, let's shift focus and look at the cardiovascular system, which consists of the heart, blood vessels, and blood volume. Consider a tank and series of pipes that circulate and filter fluid to and from the tank. This analogy can represent our patient's cardiovascular system components, where the tank and pump represent the heart, the pipes represent the blood vessels, and the fluid within the system represents the circulating blood volume. The heart keeps the blood flowing throughout the body. Its contraction strength, called inotropy, and rate, called chronotropy, change constantly to meet the body's oxygen demands. For example, the heart pumps faster and stronger during exercise due to an increased oxygen demand, but then slows down during periods of rest. The blood vessels carry blood throughout the body. Their diameter can vasodilate, or get wider, or vasoconstrict, get narrower, altering the blood vessel's pressure and the volume passing through them. And then lastly, the blood volume circulates throughout the cardiovascular system, delivering oxygen to tissue and allowing gas exchange between the alveoli and pulmonary vessels, among many other things. So, what does this dilation and constriction do? When blood vessels dilate, they widen and require more blood to fill them, reducing blood volume returning to the heart, or, in the example of the tank and pipes, the volume within the tank. On the other hand, when blood vessels constrict, they narrow, requiring less blood to fill them, which will increase blood volume within the heart, ultimately increasing the tank volume. This is why you might see an increase in peripheral blood pressure when a patient is dehydrated. It's the body's way of redirecting the remaining blood volume to prioritize blood flow to the VRG organs. Because if the tank is low on fluid volume and the pipes become more vasoconstricted, more fluid will be available to keep the tank full. Conditions that affect the heart rate, blood vessels, and/or blood volume will cause an alteration in blood pressure. The effect is that the body will respond with changes in the heart and/or blood vessels to offset the underlying condition and maintain that MAP between 60 and 150 millimeters of mercury. How does the body do this? Through signaling via the baroreceptors and chemoreceptors. The baroreceptors respond to changes in blood volume and pressure. For example, the baroreceptor reflex occurs when increased pressure, say in the carotid sinuses during intubation, or along the gastrointestinal tract during surgical manipulation retrieving a foreign body, they increase the baroreceptor firing, leading to a decrease in heart rate and then decrease in blood pressure vasodilation. Now, the chemoreceptors respond to changes in pH, oxygen, and CO2 content and primarily alter changes in respiration, but they also may stimulate sympathetic nervous system expression, or that fight or flight response. Next, let's talk about those important numbers we see on our monitor: systolic arterial pressure, diastolic arterial pressure, and MAP. The systolic arterial pressure, or SAP, is the pressure measured during the heart's contraction phase, or systole. It reflects how well the heart pumps out blood. This factor is all about contractility and vascular resistance. The diastolic arterial pressure, or DAP, is the pressure measured during the heart's relaxation phase, or diastole, indicating how well the ventricles fill up for the next heartbeat. This factor is all about volume and time to fill. And then there's MAP, the episode's VIP, or very important parameter. MAP is the organ perfusion pressure. It represents how well oxygen is delivered to organs. MAP is a calculated value derived from the systolic arterial pressure and diastolic arterial pressure values. The formula for calculating MAP is SAP minus DAP times 1/3 plus DAP. So if your pet's SAP is 120 and their DAP is 80, their MAP would be about 93 millimeters of mercury. Now, most oscillometric blood pressure machines actually measure the MAP first and then use some sort of internal equation to estimate what the SAP and DAP values are. Now, the MAP is also directly affected by cardiac output and systemic vascular resistance. So, your MAP equals the cardiac output times your systemic vascular resistance. It's not that simple. There are other factors that go into, more specifically, your cardiac output than your systemic vascular resistance. So your cardiac output is actually the amount of blood leaving the heart each minute, and factors that contribute to your cardiac output include the stroke volume, which is the amount of blood pumped per heartbeat, and the heart rate, which is how many heartbeats per minute. Now, the stroke volume, in turn, depends on additional factors, including preload, afterload, and contractility. Now, preload refers to the blood volume returning to the heart before the next contraction, similarly to diastole. And afterload refers to the resistance the heart experiences during contraction, similarly to systole. You can think of the preload as the stretch of the heart muscle and the afterload as the squeeze the heart muscle needs to overcome. Some stretching and some squeezing is good, but a lot or too little can be harmful. Finally, contractility refers to the strength of the heart muscle contraction, also known as inotropy. And then the other part of the formula for MAP is the systemic vascular resistance. Now, systemic vascular resistance, on the other hand, is all about the tone of the blood vessels. They can dilate or constrict to adjust pressures. All right, now let's talk about some situations that can affect blood pressure. Stress, be it anxiety or pain, increased steroid production, as seen in our Cushing disease patients, and activation of the renin-angiotensin-aldosterone system, or RAS, which is involved in regulating blood pressure, can all lead to hypertension, or high blood pressure. This can be a problem, especially in pets with heart disease, because it can increase the workload, or afterload, on their already overworked heart. However, as previously mentioned, hypertension also may be a compensatory mechanism in the case of dehydration, as the body tries to redirect blood flow to those VRG organs. Now, shock, on the other hand, can lead to hypotension or low blood pressure. Hypotension can be a serious problem, leading to reduced blood flow to VRG organs. It may lead to cell damage and increased lactate production, as those organs rely more on anaerobic metabolism than aerobic metabolism for their energy source. Hypotension can lead to organ damage, and prolonged hypotension can even lead to organ failure. Some causes of shock include hypovolemic shock, which develops during periods of dehydration or hemorrhage, which is primarily a reduction in stroke volume because the volume just isn't there. Examples include patients who have been vomiting for several days due to a small intestinal foreign body obstruction or a hemoabdomen due to a ruptured splenic mass. Again, this focuses on an issue with stroke volume via decreased preload. Obstructive shock occurs when something blocks the vessels returning blood to the heart, decreasing the heart's ability to pump blood effectively. Examples include GDV, which is compressing the caudal vena cava due to the gastric distension and prevents adequate venous return to the heart, or a tension pneumothorax due to increased pressures against the heart and blood vessels within the thoracic cavity. Again, this is a condition that focuses on issues with stroke volume via decreased preload. Now, distributed shock is often associated with sepsis, and in this case, the blood vessels dilate excessively, leading to decreased blood flow and a drop in blood pressure. So this condition focuses on an issue with the systemic vascular resistance. And then the last thing I wanted to mention is hypothermia. So patients that are cold may also have a drop in blood pressure. While their peripheral blood vessels tend to vasoconstrict, again, to preserve blood flow to the VRG organs, as the body function slows down, we see a delay in drug metabolism that may lead to drug overdose and a drop in blood pressure, while a decreased heart rate and contractility will also lead to a drop in blood pressure. To summarize, the heart and blood vessels regulate themselves to maintain a perfusion pressure within the 60 to 150 millimeters of mercury range and rely on circulating blood volume to achieve this. When a patient has blood loss, the cause is a decrease in circulating blood volume. Similarly, we administer most anesthetic agents to our patients, we will likely cause a change in either the heart rate or vascular tone, or sometimes both. In both of these scenarios, the effect is the body's protective response to maintain normal perfusion pressures within the cardiovascular system. Now, here's where it gets tricky. As our patients are placed under general anesthesia, there becomes a reduction or delay in their ability to respond to any cardiovascular changes because of a decrease in their central nervous system activity, courtesy of our sedation and general anesthesia. In future episodes, we'll definitely dive deeper into hypertensive and hypotensive conditions, including treatments, but for now, let's move on to the exciting world of drugs and their impact on blood pressure. Anesthetic agents can significantly affect blood pressure, and, as I've mentioned before, their effects often depend on the dose administered. As we review these medications, we will be focusing on their impact on either the heart function or the blood vessel function. So if we look at opioids, we'll administer an opioid often preemptively or in the pre-medication period when we're anticipating that the surgical or planned procedure is going to have some significant pain. So our pure mu agonists include methadone, hydromorphone, fentanyl, etc. And their impact on the mean arterial pressure is really no much change or maybe a slight decrease. And this is because their impact on systemic vascular resistance also has no change or a mild decrease. And then their cardiac output, which is going to be a byproduct of their heart rate and stroke volume, we're not really going to see much change in that either. The nice thing about opioids is that if we do overdose our patients, there is a way to reverse it, to reverse some of those side effects as well. Now, other opioids include butorphanol, which is a mu antagonist, so it actually antagonizes the mu receptors, which is why it's not primarily recommended in cases that have surgical pain, because it doesn't target those main opioid receptors. However, because it does target the kappa and delta opioid receptors as an agonist, it is categorized as an opioid. Now, the butorphanol's effect on our MAP is we may see a mild decrease. We will not see much change in systemic vascular resistance or change in cardiac output. However, our heart rate, we might see a mild decrease that may affect our MAP. And there shouldn't be any effect on the heart's ability to contract. Buprenorphine is considered to be a partial mu agonist because it has higher affinity to the mu receptors than other pure mu agonists. So instead of binding and releasing to the mu receptors, the buprenorphine will bind to the mu receptors and then get stuck and stay there a lot longer. Now, in terms of its effect on the cardiovascular function, we don't see much change in the mean arterial pressure. We may see a mild increase in systemic vascular resistance, but we might also see a mild decrease in cardiac output. So those two sort of offset each other. Now, the heart rate may mildly decrease and the contractility may not change. All right, now let's take a look at our sedatives. So sedatives are a great tool to use for our patients if we're trying to relax them in order to facilitate IV catheter placement, or maybe our patients are coming in a little on high alert and aggressive, and we want to safely immobilize them so we can proceed with admitting them to the hospital and get a catheter in them and get them ready for anesthesia. So acepromazine is primarily an alpha-1 antagonist. Now, this is dose dependent, and it's important to know that there is no way to reverse this medication. So if we give a high dose of this medication, we may have some significant issues during anesthesia, because when we target the alpha-1 receptors, as an agonist, we'll see vasoconstriction, but as an antagonist, we see vasodilation. So acepromazine's effect on our mean arterial pressure is that we're going to see a reduction in mean arterial pressure. Because we're going to see a reduction in our systemic vascular resistance. Now, we may or may not see a change in our cardiac output. Specifically, the heart may not change or it may increase. And the contractility, we may see no change or there may be a little bit of decrease in contractility. So overall, our MAP is going to decrease following acepromazine administration. Now let's take a look at dexmedetomidine. Now this medication is classified as an alpha-2 agonist. And so as an agonist, it's going to induce constriction. So this medication also has reversal called atipamezole, which is an alpha-2 antagonist. So dexmedetomidines' effect on our mean arterial pressure is going to be an increase because it's an agonist. We're going to see an increase in our systemic vascular resistance. However, we're going to see potentially a decrease in our cardiac output because we primarily see a significant decrease in our heart rate. We don't really see much change to the contractility, but because our heart rate decreases, we may have a decrease in cardiac output. And then benzodiazepines, such as midazolam or diazepam, their cardiovascular effects are actually very mild to none at all. So we do not see any change in our mean arterial pressure, in our systemic vascular resistance, in our cardiac output, in our heart rate, or our contractility. This is why benzos are a great option for patients that are very sick that we have to anesthetize, because we're going to see no cardiovascular depressing effects. The other nice thing about benzodiazepines is if we start to see some, maybe emergence delirium or effects of the medication that we don't want to see, we can reverse the benzos with flumazenil. All right, let's take a look next at our induction agents. So we have primarily alfaxolone and propofol, I think, are the drugs of choice for inducing anesthesia in general practice and in specialty practice as well. Now, alfaxolone will have a decrease in our mean arterial pressure because we'll see a decrease in the systemic vascular resistance as well as a decrease in cardiac output because there's a decrease in the contractility. And there may or may not be any change in the heart rate. Now, effects of alfaxolone are going to be dose dependent. So if we can use another drug, say benzos, to administer at the time of alfaxolone, we'll be able to reduce the amount of alfaxolone that we need. So this is the primary reason for having co-inductions or more than one drug administered at the same time to induce sedation so that we can facilitate endotracheal intubation and then initiation of general anesthesia. If we can use less of each drug, we're going to see less of a negative impact on the cardiovascular system. The same thing goes for propofol. It's very, very similar to alfaxolone. We see a decrease in mean arterial pressure because we see a decrease in systemic vascular resistance, and then we'll see a decrease in cardiac output. We won't really have much change in the heart rate, or maybe it'll decrease a little, but we will see a decrease in contractility. Next, let's take a look at ketamine. So ketamine is an NMDA antagonist, and it actually has an increased effect on expression of catecholamines. So we have an increase in that sort of sympathetic nervous system expression. So when you think of the fight or flight. So ketamine is actually going to increase your sympathetic nervous system. And so what we'll see in that case is, as you expected it, we'll see an increase in our mean arterial pressure, we'll see an increase in our systemic vascular resistance, and we'll see an increase in our cardiac output because we're going to have an increase in our heart rate and an increase in our contractility. Although, if we give this medication at higher doses, it can have a negative inotropic effect, so we can see a decrease in contractility. The other thing to note is that patients who are what we call catecholamine exhausted, which is when they've been under conditions of stress or increased sympathetic expression for an extended time, they're actually going to see a reduction in cardiac output and inotropy. And it's important to note that we can't reverse the ketamine once we give it. So patients that are really sick, we may avoid using this medication. However, for our healthier patients that we are going to maybe give propofol or alfaxalone to, if we actually give ketamine, there's a nice benefit to that, because while propofol will decrease our mean arterial pressure, ketamine will increase our mean arterial pressure. So we actually will help to offset any cardiovascular depressing effects of propofol, and we may see, we may not get that drastic change in blood pressure. So ketofol, what our hospital refers to it as a combination of ketamine and propofol, is a drug of choice that we'll use for our healthy patients or our younger patients where we know that they rely more on their heart rate for maintaining blood pressure. So if we can give them a stimulant, such as ketamine, then that'll help to keep their heart rate up. We won't see that drop in heart rate during intubation. And then the last drug to review for an induction agent is called etomidate. Now, etomidate actually is preferred in patients that have pretty significant cardiovascular disease because it doesn't have any effect on the cardiovascular system. So we don't see any change in the mean arterial pressure. We may see a mild decrease in systemic vascular resistance, but that sometimes can be preferred in patients with cardiac disease because it's going to decrease that afterload or decrease that workload, and the heart might pump a little bit better because it's under less resistance. And then in terms of the cardiac output, we may see no change or maybe a slight decrease, but the heart rate might increase and the contractility, again, might decrease a little. So the general net is that there really isn't much change. So etomidate is a great option for patients that are cardiovascular or have the risk of becoming cardiovascularly unstable. But there's a caveat to this as well, and that's the inhibition of 11B hydroxylase, which what it'll cause is suppression of adrenal function. So this can lead to an Addisonian crisis, especially in patients with decreased adrenal function. So again, those sort of like catecholamine exhausted patients where they just don't have any more adrenal squeeze left, nothing left there for them. So we avoid etomidate in patients, even though it's great for cardiovascular stability in the moment. 12, 24 hours later, we might have them in this sort of Addisonian crisis where we're having to administer them some sort of steroid medication. So etomidate is great for patients that we are not worried about suppressed adrenal function, but we have to be mindful that if we give this medication, we're keeping an eye on their stability in the day to follow. Okay, now let's take a look at our inhalant agents. So the primary ones that I like to focus on in these episodes, which I think are the ones that are the most common in veterinary practice, are going to be isoflurane and sevoflurane. The overall effect on their on the cardiovascular system is we're going to see a decrease. So we're going to see a decrease in our mean arterial pressure because we're going to see a decrease in the systemic vascular resistance. So the patients are going to vasodilate, again, in a dose-dependent manner. And then in terms of our cardiac output, we may not see much change, or we may see a mild change, more specifically because we'll see a potential decrease in their contractility. If we can reduce the amount of inhalant we're using, we can see less of those cardiovascular depressing effects. The other medications I want to talk about really quickly, one is lidocaine. So lidocaine is a sodium channel blocker. It's an antiarrhythmic, so we use it in our patients that might have some ventricular tachyarrhythmias. At lower doses, we can see some analgesic effects. It also helps with scavenging free radicals. So as we have this reperfusion, we have an increase in lactate production. The lidocaine can be a great sort of antioxidant for these patients. So the cardiovascular side effects, we don't really see a change in our mean arterial pressure following lidocaine administration. Now, what I will say is that the doses that we're looking at are primarily within clinically recommended doses. So my hospital doesn't really go much higher than 80 mics per kg per minute. Again, more using that dose for antiarrhythmic benefits than analgesia and MAC sparing. But the doses that we'll sometimes start with during anesthesia as a CRI might be 30 to 40 mics per kg per minute. And you can see a pretty significant MAC reduction in inhalant usage with lidocaine. So the systemic vascular resistance, we won't really see a change. However, we might see an increase, again, at higher than clinically used doses. And then we won't see much change in cardiac output either. We might have a little increase in heart rate, but there won't be any change in contractility. The reason I brought this drug up is that if you have a patient that is going under anesthesia for a procedure and you're really concerned that the inhalant is going to impact them significantly in terms of their cardiovascular stability, starting a lidocaine CRI, whether it's with fentanyl or just by itself, can help to reduce the amount of inhalant that you need to give. We always want to have in our arsenal drugs that we can use that have minimal to no cardiovascular effects so that we can add those into these cases and help to make our anesthesia maintenance safer. The other drug that I wanted to review real quickly is a class called anticholinergics. Now, you've probably heard of this before, but they are antagonists of the cholinergic receptors, will decrease parasympathetic nervous system expression. And so your parasympathetic nervous system expression can sometimes be increased during anesthesia because it's the opposite of the fight or flight, right? It's the rest and digest. So we've got all these drugs that are sedating our patients, that are targeting analgesia, that are relaxing them. And so as the sympathetic nervous system is suppressed, we start to see an overexpression sometimes during anesthesia of the parasympathetic nervous system. And so anticholinergics, what they will do is they're actually going to block the parasympathetic nervous system expression, which in turn is going to increase sympathetic nervous system expression. So in terms of cardiovascular outcome, we actually will see an increase in our mean arterial pressure. We'll see no change to the systemic vascular resistance, but we will see an increase in our heart rate, which will increase our cardiac output. Now, there really isn't much change on contractility, so we're primarily targeting the heart rate to then increase cardiac output to then increase our MAP. Now, I also want to talk about some of the medications we might have our patients receive prior to coming to the hospital. Trazodone is a medication that we use a lot in our hospital for reducing anxiety coming into the hospital, so we can have our patients are calmer and more tolerant of IV catheter placement, of radiographs, of the physical exam, and they're just calmer. And I think that it really impacts their stability during anesthesia when they come in calmer and they're going under general anesthesia and they're not freaking out. I find that they don't freak out as much going into recovery and coming out of anesthesia. Trazodone is primarily a serotonin reuptake inhibitor, so it's going to increase the amount of circulating serotonin within the brain and as a neurotransmitter, and that is one of those calming, feel-good chemicals that are naturally occurring. So if we can increase the amount of serotonin present, we'll see an increase in calming and comfort. Very rarely, but in some small instances, we see the opposite effect, and it actually freaks them out more. But most of the time, it actually will help. At the doses we're giving, it will help our patients' anxiety coming into the hospital. So the antidepressant effects and reduction in anxiety are primarily due to the serotonin reuptake inhibition. And then there's also some information out there that says there might be some alpha antagonist or alpha-1 antagonist and histamine blockade that can lead to some sedation. So this medication has more than one mechanism of action in terms of receptors that it targets, but primarily as an antidepressant or anxiolytic, it's the serotonin. Because it does have some alpha-1 antagonistic properties, again, alpha-1 is a receptor on the vessels. If it antagonizes, it will dilate. It is suggested that trazodone has similar effects on the cardiovascular system as acepromazine. It's also noted that while there is a MAC reduction in isoflurane with pre-medication of trazodone, there's no cardiovascular difference in stability when comparing patient group that received trazodone preoperatively and had a reduced MAC versus patients that didn't receive trazodone preoperatively and were run at the higher isoflurane concentration. So in this instance, or in this paper, it was Hoffman et al., I think in 2018, whether a patient received trazodone and was run on a lower inhalant level, the cardiovascular values were the same as a patient that was running on a higher inhalant whether or not you decide to use it as a benefit or to argue the benefit of it being a MAC reducer, I think, again, it goes with what other drugs are we also considering, and do we, this doesn't include having opioids on board. And when we have opioids on board, then we get even more of a MAC reduction, or lidocaine, we get a more of a MAC reduction. So there's not a lot of data out there. So this is something that I think is an area that requires some more studies to really look at the pharmacokinetics of trazodone with other drugs, say CRIs, during anesthesia. Whether your team chooses to use it, in practice, I think from the primary goal of trazodone with anxiety, it does play an effective role in reducing anxiety and improving the calmness of them coming out of anesthesia. And we can address the cardiovascular stability during general anesthesia with some other drugs to further reduce the MAC, and then maybe we'll see an improvement in the cardiovascular values that we're seeing on our monitor. And then the last drug to review is gabapentin. So gabapentin actually has no known cardiovascular effects, and it will really help with improving patient handling, specifically for cats. So cats that come into the hospital, they're pissed, they're stressed, there's all these smells, all these dogs. This is not their home. I mean, their resting heart rate for the most time is like 200 beats per minute. So, having that sort of high anxious stress anxiety for like a prolonged period of time can't be good for their heart, and their cardiovascular system. So having pets come in, cats specifically coming in with a dose of gabapentin prior to hospital arrival, it will allow us, to improve our handling of these guys and maybe get an IV catheter in them without having to give them additional sedation before we proceed with their procedure. Trazodone and gabapentin, this is my little throw in there of recommending it, to start the pre-medication process sort of at home. Now, we're going to look at some common scenarios that we may see during anesthesia and try and work through the primary cause of that specific, hypotension. So our patients are under anesthesia and our blood pressure is low. What do? It comes back to that formula, MAP equals cardiac output times your systemic vascular resistance. We need to know what part of that formula we're treating. Is it a heart issue? Is it a vessel issue? Is it a volume issue? So if we're looking at cardiac output, we have heart rate, we have stroke volume. So if we have a decrease in heart rate, that is also called bradycardia or bradycardia induced. So our patient is hypotensive, we need to look to see what the heart rate is. If the heart rate is low, likely this hypotension is just due to an overexpression of the parasympathetic nervous system, specifically from opioids, from the propofol induction, things like that. The treatment for bradycardia-induced hypotension is to administer an anticholinergic and kick that heart rate up. It's going to improve our mean arterial pressure and hopefully resolve our hypotension. Now, what happens if our patients are bradycardic following alpha-2 agonist administration or dexmedetomidine, right? Everyone sees the heart rate of 35 or 30 beats per minute following administration of dexmedetomidine. In most of those instances, if your pet's under anesthesia and your heart rate is low and that's the thing that's triggering you to be like, oh my gosh, my heart rate is 30 beats per minute, what am I doing? The next thing again is to say, is that heart rate low causing hypotension? And in most cases, following dexmedetomidine administration, you're not going to see hypotension. You're going to see hypertension. Remember, because the bradycardia is the protective reflex from the heart to maintain normal perfusion pressures because the systemic vascular resistance skyrockets. So if your patient received dexmedetomidine and is bradycardic, most times you're not going to see hypotension and you're not going to have to do any interventions. Now, what happens if you've given them dexmedetomidine in the pre-medication phase and now we're 20, 30 minutes into anesthesia and your heart rate is still 30, 35, maybe 40 beats per minute, and now you're seeing peripheral vasodilation, so your MAP is, say, 45 or 50. What do you do in that instance? Well, this is where it gets a little tricky, and it depends on who you talk to. So in general, anticholinergics are not recommended to be given to a patient following alpha-2 agonist or dexmedetomidine, medetomidine administration, because you're going to just force that heart into overdrive, and it's not going to get enough oxygen delivery, and it's going to have some, cardiac ischemic events. So, among other complications. So then you get to this phase of, well, we're no longer hypertensive. So is it okay to give anticholinergics? And there's some studies out there. There are some studies that are being performed now to look at the effect on the cardiac function in administering an anticholinergic. So I have in the past, from approval with the criticalist or anesthesiologist, given an anticholinergic to try and offset the bradycardia, which then will improve the blood pressure. Again, this is a situation where the bradycardia from the dexmedetomidine has now become the patient's also hypotensive under anesthesia. So giving an anticholinergic may be an option at that time. It is not, however, recommended to reverse the medication. So there's several studies out there that show that reversing the dexmedetomidine will actually worsen the hypotension, which makes sense, right? Because we're giving the reversal to dexmedetomidine is an alpha-2 antagonist, and antagonists lead to vasodilation. Plus, it also is going to wake them up a little bit. So then you're going to have to crank up your gas even higher, which is going to further vasodilate them. So for multiple reasons, it's not recommended to reverse the dexmedetomidine. What if we give dexmedetomidine during our pre-medication and then we just start them on a CRI, so a continuous rate infusion, which is really great at MAC reduction and maintaining that sort of like sedative anesthetic depth. That's another thing to consider. And usually in those cases that are given a dexmedetomidine as a pre-medication and then run on a dexmed CRI, you don't see the hypotension. You see the bradycardia, but you don't see the hypotension because they have this constant exposure to this alpha-2 agonist medication. The last thing I want to talk about with dexmedetomidine is ketamine. So I know there's a lot of papers out there that look at the quality of the sedation score when it comes to dexmedetomidine and ketamine administration. However, most of those studies lack looking at the workload on the heart because they just don't have those monitors in the patients when they're evaluating and assessing the quality of the sedation score. So in those instances, and I'm on the, depends on who you talk to. There's, a little bit of a debate out there, or two sides to this, is whether or not you use ketamine and dexmedetomidine together. I am in the camp that doesn't use those two drugs together, again, because ketamine is a stimulant. And so similarly to an anticholinergic, it's going to increase sympathetic nervous system expression, and you're going to bypass the patient's protective response of bradycardia by giving ketamine or a drug that's going to increase sympathetic nervous system expression and say, I don't care that your heart rate is low, you're beating faster. And that's going to really increase the workload on the heart and can really cause some damage to the heart muscle itself. So hopefully we've got some studies in the future that will help to shed some additional light on that. And maybe I'll change my mind. But there aren't really many studies out there that focus on the cardiovascular effect, on the myocardium and that muscle when you give the ketamine following dexmedetomidine administration. So again, another topic. Hopefully I'll have a guest on and we can hash out that and debate it and look at both sides of it. And then the last type of bradycardia-induced hypotension is going to be due to high vagal tone. So I know I mentioned the baroreceptor reflex earlier. We've got the oculocardial reflex. So if there's increased pressure on the eye, we get this like baroreceptor response that there's too much circulating pressure. We have to slow down our heart rate. But it's associated with one area, right? So they're assessing high pressure, within the along the ocular nerve or within the carotid sinus from intubation, or even when we initiate positive pressure ventilation. With one area in the body, they're sensing an increase in pressure, and so they're telling the heart rate slow down. There's too much pressure. But in the other areas of the body that aren't under that high pressure, they're going to then become hypotensive because they're not getting enough cardiac output. So in this situation of high vagal tone, it's actually recommended to give an anticholinergic as well. Okay, so that was the heart rate part of cardiac output. The other part of cardiac output is our stroke volume. Now, if we have hypotension that is associated with stroke volume, we have a decrease in blood volume. So it is hypovolemia induced, We can have dehydration. So our patients that come in vomiting for several days have lots of water losses. They're interstitially dehydrated. Their blood is sludgy. It's dark. It's thick. They're going to require volume to improve the blood pressure. Now, hopefully, you're not having to rush these guys into anesthesia for the procedure, and you can get them on some balanced crystalloid fluids, whether it's boluses initially and then maybe a maintenance race, and delay anesthesia and surgery as much as you can so that they're more volume stable before we initiate anesthesia, because we're just going to exacerbate it when we anesthetize these guys that are really volume depleted. And during anesthesia, we'll see some additional evaporative losses, say from the open body cavity surfaces. So if you have an anesthesia that's lasting 3-4 hours because it's very complicated, laparotomy, you have to keep in mind that if we're running these guys at 3 to 5 mils per kg per hour of crystalloid fluids, we may wind up in a deficit a few hours into the procedure. So I get distracted very easily. Anyone that works with me knows that I get distracted very easily. So I have to leave myself little reminders and checkpoints, which I've gotten very good at doing in all my years of practice, but it did take me a while to get to this point. One of those checkpoints is that I only ever set my volume to be infused on my fluid pump to 1 hour, so that after an hour of anesthesia, I'm getting this trigger to remember to assess my patient's hydration status and potentially change the rate of volume that I'm giving them of the crystalloid fluid. So I every hour will check that. Obviously, I'm monitoring them more closely than every hour. And so there are situations where I get 30 minutes in, I'm like, okay, this guy's now really showing me signs of hypovolemia. I'm going to give them a bolus of fluid. And then the other type of hypovolemia induced is going to be bleeding, so hemorrhage. So again, the interventions for that is initially going to be balanced crystalloid fluid boluses and then blood products. And then the last thing for us to look at in terms of the MAP formula is when we have hypotension associated with a reduction in systemic vascular resistance. Now, most of the time, this is going to be what we call inhalant induced, because we know that of all the medications that we have in our anesthesia arsenal, the inhalants are going to be the ones that have the highest impact on cardiovascular depression. Easy enough would be if our inhalant-induced hypotension is secondary to a deep anesthetic plane. So if we do an assessment on our patient and we recognize that they have a loose jaw or their eyes are central, their negative palpebral reflexes, it's easy enough where we can just go ahead and turn back our inhalant percentage, and in turn we should see an improvement in blood pressure. However, sometimes our patients are actually going to be at an adequate anesthetic depth and hypotensive. And in those situations, there's two options to approach this. One would be to administer a medication to further reduce the amount of inhalant required. This would be in the form of a CRI, whether it's lidocaine, which we know that lidocaine doesn't have any negative cardiovascular effects. However, it does provide some MAC-sparing effects. So if we add in a drug that will maintain our anesthetic plane and allow us to reduce the inhalant, we should in turn see an improvement in our blood pressure. Another analgesic or another CRI could be an analgesic such as fentanyl, again, targeting the pain signaling associated with the surgery. If we increase the analgesia on board, we should be able to increase the amount of inhalant our patients need to maintain that adequate anesthetic depth. And then the last thing we could consider in terms of MAC sparing would be using some sort of local block, ideally prior to the start of the surgical procedure, so we have those peak effects on board. But that again is going to reduce the signaling that the patient's getting in terms of pain, which can lighten their anesthetic depth. So local regional analgesia is great, and then MAC sparing CRIs are a great alternative as well. On the flip side, if we were to assess our patient and say, we've got our local regional analgesia on board, maybe we've given a CRI or an additional bolus of an analgesia, and our anesthetic depth is adequate, and we don't want to add in any other medication that might decrease the MAC, the other alternative is we could instead give medications that are going to target the vasodilation. We're going to administer a medication, a CRI, called vasopressors. Now, vasopressors include dopamine, norepinephrine, dobutamine as some examples that primarily are going to target the alpha receptors. So if we target alpha 1 and alpha 2 receptors, we're going to see some vasoconstriction. So using a vasopressor is another option to help with improving blood pressure if we have inhalant-induced hypotension. And then the other CRIs that I didn't really mention would be considering to add in a sedative CRI, which to some degree have their own negative cardiovascular effects, but a propofol CRI or alfaxolone CRI can sometimes provide less significant cardiovascular depression than the inhalant, and it will in turn allow you to reduce the amount of inhalant present. Now, what happens if we've given our patients, say, ace-promazine, or maybe they received Dexmed earlier and then we reverse them, but now we're ready to start anesthesia. So they have an anapamazole on board or an alpha-2 antagonist. So ace-promazine, as I mentioned, is an alpha-1 antagonist, and anapamazole is an alpha-2 antagonist. Well, the alpha receptors are the ones that are present on those blood vessels. And so if those are being blocked and being which is preventing binding of norepinephrine, which will lead to vasoconstriction, this puts us in a little bit of a pickle because we can administer a drug such as norepinephrine, which is going to target those alpha-1 and alpha-2 receptors as an agonist, but we've got this drug in the way that's going to prevent the full effect of norepinephrine. So it's really not going to work very well for these patients. So it's important to keep that in mind when we're considering giving either ace-promazine or atipamezole to our patients before anesthesia. And this is why, for ace-promazine, in my practice, I rarely go above 0.01 mg per kg dose as part of my IV pre-medication, maybe a 0.02 mg per kg dose for IM administration, but we're starting with really, really low doses so that we can avoid the vasodilation that we can't really treat during anesthesia. But if you have vasodilation that's secondary to either ace-promazine or atipamezole administration, the recommendation would be to start by adding in norepinephrine. And again, it won't be as effective due to the antagonistic effects of both the ace-promazine and anapamezole. And hopefully you don't have both of those on at the same time. But if you've got the ace-promazine on board, then at least your norepinephrine is going to be targeting some of the alpha-2 receptors, and vice versa. If you've got the atipamezole on board, hopefully you don't also have ace-promazine on board, so your norepinephrine can be targeting primarily those alpha-1 receptors. Okay, there you have it, a whirlwind tour of blood pressure and anesthesia. Understanding how these factors interact is essential for providing safe and effective anesthetic care to our furry friends. So in closing, let's review our CARES Action Challenge for this episode, which is standing up for someone. Imagine witnessing someone being targeted with negativity or disrespect, whether they're present or not. This is a powerful moment to step up and be an ally. It might feel uncomfortable, but standing up for someone, even when it's hard, is an act of true kindness and respect. You're showing that you value their worth and acknowledge the harm being inflicted. By speaking out, you're not just defending the individual, you're fostering a culture of empathy and accountability, creating a space where everyone feels safe and valued. Remember, you don't need a leadership title to make a difference. Showing your support for others creates a workplace where compassion and consideration are valued. A great way to start speaking up is by playing devil's advocate. This will challenge them to see the situation from a different perspective. Who knows? It may inspire others to reevaluate their thoughts and actions too. And that's a wrap. Thank you for taking time out of your day to listen to this episode. I hope there was information discussed that will be helpful for you in your practice. If you have any feedback or suggestions on this or future episodes, including joining me to talk about anything anesthesia or veterinary medicine related, or hey, even life lesson related, really, anything that you are passionate about, I'd love to hear from you. You can email caresvetmed@gmail.com or connect with @CaresVetMed on Facebook, X, Instagram, TikTok, and YouTube. This podcast is available through Apple Podcast, Amazon Music, Spotify, YouTube, and on caresvetmed.com. Please leave a rating or review on this or any of the episodes to help encourage new friends to give us a listen. It would be greatly appreciated. And lastly, I encourage us all to take a moment out of our day to take pause and remember why we chose this profession. The days may be long, the cases may be challenging, but watching a pet reunite with their family makes it all worth it. Take care, friends.